And I'm really happy to see the number on Saturday evening. That just means that I also don't have life and you also don't have life. Right? So that's fine. We are here to learn something. And this is a very important topic, I will say, because when we enter in post graduation and suddenly something comes that, okay, your name is there on academic schedule and you are going to present a journal club. Most of the time, we do not have idea what is this journal club, and it's completely fine not to have idea. The sad part sometimes is your mentor also does not have that idea. So with all respect, we are not taught that how to do a journal club. Takes lot of time, and what is the real meaning of that? Many of us pass MD without knowing even that. So that is also still fine. The problem starts when you start your practice and a person comes to you from a marketing or anywhere that, sir, we have this XYZ product, and according to this trial the products works beautifully and you can prescribe to your patients. The problem starts there. You should be able to judge that article whether really that product drug intervention works or not. Okay, when you start judging this thing, then it becomes more and more evidence based medicine. So the sole purpose of journal club is not to screw postgraduate. It is actually to make postgraduate learn that how to read an article. The worst part what happened to most of us is when we join college and then MD, specifically post graduation, let it be any branch, journal club is in every branch, right? Even in DM you are going to deal with journal club. So when we join it, and the first question is what is journal even, because we were so used to textbook and, with all respect to the notes what we are using, right? So we are so used to that that we are sometimes not sure what is even a journal. I had no idea what NEJM is there during when I joined my first year of IMD. I should have, but it was not there. Then slowly I came to know, okay, these are journals and all. So I'm going to go on very basic today, that when this journal club word comes to you or your name comes there, how you are actually going to approach and how you should select an article, how you should read an article, and how you should make your presentation. Because everything matters according to me. Someone will say, ki, what is the point of being so research oriented? At the end of the day, does not fetch any money, right? So there are people to say that, but it's your choice. After class you decide that you want to read article properly, or just for that you want to read abstract, or you want your friend to say कि ये कल publication में क्या आया था, right? What came in yesterday's publication. So it's up to completely up to you, right? But believe me, it changes your practice. And if sometimes some people mention that okay, my practice is according to that article and I know what is new in the world, then I will start believing those doctors and start referring my patient there. Okay, so we will start here. The outline of presentation is how this journal club concept started, why we need journal club, what are the steps to prepare a journal club, and what can be the possible outcome of a journal club. Okay, so it all started somewhere by James Paget in 1854. It was very informal thing, that what he described, that self-elect of the pupils making themselves into kind of a club, had a small room over a baker's shop near the hospital gate where we could sit and read the journals, right? So kind of it was just a very informal talk that, okay, this is what is coming and we will discuss something about this. Then the came the father of medicine, or father of modern medicine, William Osler, who probably did a proper organized journal club at McGill University in 1875. And then later, if we say the evidence-based medicine era, which actually starts somewhere in 1990, that the importance of journal club came. Believe me, this is the point. The skill of having a journal club is most important, because if you just open your Medscape or Up to Date or your PubMed, in a day so many articles gets published. We should actually know how to read and what to read. So this is the era of infodemic. If we do not know how to interpret an article, we will be fooled. Okay, because it was something that still now I think my reference always has been, okay, this has been given in Harrison, so it is standard. Then people actually come over that and keep telling it, this also has been published, which is not mentioned in Harrison. So that time you have to decide whether this publication is superior to Harrison or not, right? And that is the point. You should be knowing to see a journal article. I don't want you to be expert on criticizing someone's work. I just want you to know how we read an article and how we take a summary out of that. That will be the entire goal of this discussion. The next, what we see is why we need them. So the first thing is the journal club will link the research to clinical practice, right? So someone has published an article and we have habit of just reading textbook, then we may not be updated so much. But if we have this kind of journal club that, okay, after 20 days, you have a presentation on a new article published in NEJM few days back. So actually, and then on that discussion, you might change your practice little if the article was so solid. So that is something a research to clinical window a JC can provide. It acts as a vehicle for the application of the evidence-based medicine through continuous medical education. It allows academic debate and networking, specifically if you have colleagues and mentor like that. And it helps trainee to develop their critical appraisal skill. And sometime in the class or seminar, you get whatever we are looking forward. So this is something, this class is not to remember them anything. Okay, it is just to understand. This is not your theory question. Okay, so forget the exam, just enjoy what is being told, right? So these are so-called benefits, but what I would say, the best benefit you can get is a publication generation. You read an article very properly. After reading that article, if you find a point to comment or highlight, okay, this could have been done like that, or this is done properly, but the data in my context or the my center context or the our center context tells this, that is the point of you will see letter to editor and something. If you keep reading any journal regularly, there will be multiple sections, right? First will be editorial, then there will be original research, then there will be review article, then there will be image of the week, then you will have basic research, then you will have letter to editor. Letter to editor is mostly when someone does a critical analysis of a published article and has a comment to say, that gets in a publication, right? It does not count much as a promotional publication as per Indian system, but it counts that, okay, this is one of the way to analyze the thing. Okay, so someone tells that I have a publication called letter to editor, I will actually judge that person, okay, he has that much zeal to read an article and to write a comment on that. Okay, so it might be better than a original article sometime, because it just tells about the sincerity, the way things are going on. I know it is too much, but in academic institute, you deal with all this thing like this only. Okay, so these are the benefit of that. So now this were the kind of introduction, that who started it and how it was started, and the next, that why we need them. Now we come to the main body of the article. Just a second. Yeah. See, this happens in private practice. If you have too much of the research orientation, you feel like this. It's fine sometime that, okay, we adapt to the things and the life goes on, right? So these are the steps for a journal club preparation. So whenever you get a journal club and your name is written in front of that, what are the steps? The first step is selection and approval of article. The second step is dissemination of the article in prior to your colleagues, means to your club. You prepare the presentation, do the critical appraisal, and then you have a presentation. Okay, so these are the steps to go through. Now, most of us get stuck in step one. My journal club is there day after tomorrow, and still today I do not have any article. So I keep asking my senior, or if any staff who is a kind of friendly, that, yes sir, what is the what should I present and all. Sometimes they also do not have idea that how these things work. Okay, so the first is the selection of article. Now, so whenever you get this journal club, the selection is very simple. See, we are, I assume we are medicine people. We are medicine postgraduates most of the time, right? When we are doing it, or let it be any postgraduate for a fact. So in your specialty, super specialty or subspecialty, the journals you should know. So for medicine, I will say it is always, like, I'm not promoting them or something, but it is always NEJM, Lancet, JAMA, BMJ, Annals of Internal Medicine. There are 5-6 journals. Then there is a journal called Chest, Blood. There are 6-7 standard journals from which you should select an article. Now, whatever journals I talked about here, they are high impact factor journal. Means they are being cited more and more, they are being read more and more, and they accept a high quality research, right? So what you are going to discuss with your colleague, let's at least ensure that people have tried to make it better, because we are getting from the best journals which are there in the right now in publication process and all. Okay, so select a journal first. So you go to a journal that suppose you go to NEJM. Now you see the NEJM last 1 month, and you will see so many kind of article. What you are supposed to select is an original research or something written original article. You can't have editorial in your journal club. You can't have review article in your journal club. I have done this mistake, so I'm just telling you that don't repeat it. I went with 4 review articles in my first JC in my PG, and my mentor was laughing on me that we do not present review on JC. We present original article in journal club. So it's okay. We have to learn at one point, so we have to be full at one point, right? So that is the thing that okay. No, we know from a standard journal with an original article, you are going to your guide, and he may select one out of them, and then that the second step will start. This is the dissemination of the article to your colleagues. So I'll just show you a few examples. That see, this is something which was during my DM tenure, and this is the time. It is September 13, 2018. So I wrote to my mentor that I have a presentation to be done, and I have selected 4 of this article. You guide me to select one. So the mail was sent on September 13 to the guide. So I think for every JC, they try to allot one mentor, one professor, or someone to you. That is usual thing. If that is not happening, you go to the person who is making academic schedule, that with whom I should discuss that what articles is supposed to be presented, right? Because otherwise it happens, you present some article and someone will tell ki this is useless article. So it is always blame to people, right? That it is I am not the only one who is useless, or my mentor is also useless. Okay, I was in a different scene completely, that my mentors were great actually to learn things. Okay, so this was mailed on September 13. On September 15 I receive a reply that what you have done is a good selection, but I am sending you additional 2 more article. If you want to select from that. So that is the point I told, okay, we will go with this. Okay, so this step 1 is something which is lacking in most of the medical college. I'm not still blaming anyone, it's completely fine. But when you know, your prof know, then only things works very easily. So this is the first step. Go with original articles, tell them that these are my choices, and if you insist, sir, anything else to be done, you tell me one article. Most of them they will say what you have selected is right. Okay, so the first article you have to keep, which actually out of 4 you want to present. Okay, I always used to do that. I go with 4 because the formalities go with 4 5 and they will select one. But you try to convince them that what actually you want to present, which is your comfort zone sometime. Okay, so I try to find my comfort zone. If someone tell me reproductive endocrinology article, I cannot present. If someone tells me neurology, rheumatology, something, I am quite comfortable to present those topics, right? And believe me, when you present a journal article, you do not need in-depth knowledge. Okay, someone tells me I am going to present rheumatology, but I do not know much rheumatology. It's completely fine. When you are actually discussing the rheumatology is a very minuscule part of that. It is more of the article method, which will be the major part of that. Okay, so the first step is get the approval. Now, see, second, what I am again telling, that dissemination of the article prior to your journal club. So I had a JC on 1st May 2019, and I am sending mail on April 17 to my colleagues that, okay, this is my article, which I am going to discuss in detail. Okay, see, these are the 2 steps which will actually tell about our institutes and academic programs, that how sincere they are to do that. If they're not sincere, it's completely fine. This is how the country is being run, right? So that is fine. But at least when you reach, because see, that transition comes that sometime from a college you have done MD and we do not have any orientation. You get to the DM, maybe PGI, JIPMER, or wherever you're going, where they are so particular about all this thing, and we get stuck. My clinical knowledge is so good, I can treat my patient, but when this JC and all come, I feel little low, because I was not exposed to that during my training. So that is none of your fault. You just know the process, and I believe that in second year everyone becomes good, because the only necessity is to go through the process. So you have to go through, and these are the initial steps. So when your name comes to JC, that's a point. You select articles, meet your mentor, You select article with your mentor and then you disseminate. Okay, see, what I am talking is actually not completely useless. That's the most important step. I know we are waiting for the main thing here. Just tell us that how to make the JC, right? So I will come to that. Don't worry. This is the thing. Okay. So what we know that if you have any article today, I shared, I think, one PDF of the same article, that this is the article. If you have that, you can open it, or you can open any original article. Okay, so the article is divided in few parts and you have to read by parts only. So I'll be telling what to figure out when you're reading those parts. So the first part is you will read title and author. Okay, now see, this is one of the best journal in rheumatology and also rheumatic disease. And if we have a publication in this, it's a kind of a show off moment for us that I have paper in ARD. I do not have. I have just one letter to editor in ARD. I do not have original paper right now. Okay. So that is the point. This is one of the highest impact journal. So the selection of article is from a proper journal we are doing. That makes a lot of sense. Now you see the title of the article. What is written? Gradual tapering, TNF inhibitor versus conventional synthetic DMARD after achieving controlled disease in patient with rheumatoid arthritis, first year results of the randomized controlled TARA study. So whenever you are actually publishing a JC, you have to select a randomized controlled trial. Ideally, it is not rule, but just for a convenience, we try that. If it's a JC, we go for a randomized controlled trial, clinical JC, because when you will enter in DM, there will be two kind of journal club. One is clinical journal club and one will be the journal club called basic journal club. So whenever we select clinical journal club, we have to select a randomized controlled trial. Now see the article title. This is one of the best journal, and see the title, how simple it is. The simplicity matters. Okay, because someone tells ki no, we have a breakthrough in medicine, breakthrough in hypertension, breakthrough in rheumatoid arthritis. We found a cure of rheumatoid arthritis, right? So that kind of label, which is sensational, it is off thing. Do not select those articles. Those are dabba articles. Okay, so it's not newspaper, right? It's a scientific journal, so it has to have a very relevant meaning. Second is the authors. I'm not going to discuss much about the authors today, but you have to see specifically the authors are in the same area where the article has been published. It's more of a journal's job, but still, when you are critically analyzing so much, then it is there. You might get a job as a reviewer once you start publishing and all. At that point, we take care of that part. Okay, because there's something called guest authorship. I'm publishing, then I will tell my friend or my wife or someone that Chal tera naam bhi, let me include your name also. Okay, because you are just my friend. That does not count. That should not happen. Okay, so now there are so many rules about authors, who should be author, but we have to see that part. That is quite important to know. So article, whenever you read title and author, the first thing, does the title clearly communicate the study's content? After reading, you have a common thing here, that when we are tapering drug TNF inhibitor versus conventional DMARD in a patient of RA who has achieved a control, what will be the analysis after 1 year? So it is kind of a simple message, what is given in a simple language. So it's a clear title. Is the title free from sensationalism, right? So this is something, otherwise if author would have written that you can stop therapy in RA, a TARA study, then I won't read that article. It won't be even published in this journal called and also rheumatic disease, right? So these are simple small steps which will matter and you have to analyze it. So whenever we are selecting an article, Google is no way to select an article. You should know the journal of your specialty, be it medicine, be it cardiology. For every specialty, there are few journals you should be knowing. From that, you select an article. Okay, when you will enter in specialty or when you are in medicine, you will actually come to know about this. Okay. So this is the first point, you take care of that. And most of the time, this is the first slide of your even a journal club presentation. Okay. Now, since one common mistake what we do and what I have seen here, that when we are presenting a journal club, we present it as if it is our own work, that we did this study and we found this. No, man, we did not do anything. We read the article and we are presenting the article. So they did study, they found this, and it was their work. Do not take credit. It was their work. Okay. So this happens, like people have done it and it's completely fine, because we do not know that we should not do that. Okay. Now we know. So we do not take credit on someone's work. They have done it, and we will give them credit and we will criticize them. Okay. Because sometimes the professor asks that they could have, like in this article, the drug given was, the interval was not correct, and we become so defensive. No sir, we gave at correct time. We did not do, they did that. So if your prof is finding mistake, it is not your mistake, it is their mistake. Okay, so that is the point. And most of the time, you believe me, it is not even their mistake. We do not know what is exactly happening, specifically if you are going to a good journal. Okay, so this is the first point you are going to analyze. The next thing is abstract. We all do this mistake. We just read abstract and go away. Okay, this is good article, this is the summary, this is the result. But reading abstract and reading full article has lot of difference. Okay, and this is how we feel. And I just love this time that where I can teach medicine with memes also sometime, right? That we just read abstract and introduction, and the rest of paper will be like, no, read this. This is what the message is. Okay, so the abstract part never becomes a part of your journal club presentation. Do not keep there. You keep title, you keep authors, and then move to introduction. Now, when you read introduction, what actually you are looking for? See, you might, if you are entered in the postgraduate, or if you have done some study as undergraduate, you must have written the thesis protocol, right? So the thesis protocol introduction is the most important thing. Many of the time it happens, the seniors have done this thesis, we copy from that. Okay, that's a terrible thing, but that happens. We know everything now that what is happening. So let's accept the fact and try to improvise on that. That is on in our hand, right? So whenever we make introduction, what we are actually trying is, okay, we have a topic in mind, or your guide has a topic in mind. On that topic, you actually have to see what currently the literature exists, what is the gap, or where is the area the research is pending, whether that is feasible to do here or not, and then ask the right question. So these are the few things. The introduction, when you read, it gives the idea about the need of conducting the trial. Now, if someone tells me that I want to compare atenolol and metoprolol in hypertension, that's my thesis topic, I will upfront reject it. Why do you want to compare it? Okay, so the article should be relevant enough, which is the research need. It gives idea about the existing evidence and lacuna of the same. It explains the rationale for conducting study. It gives idea whether it's novel or not, and helps to justify the objective of study, right? So it's like setting the background, whether the author has set the background correctly or not. That is the point we all are looking actively here. Okay, so this is the introduction, what you write here. And introduction is the part in postgraduate journal club. You do not give much importance, but you give a 1 or 2 slide there. Key, the area is this. The area is rheumatoid arthritis. In rheumatoid arthritis, if you respect this title, in rheumatoid arthritis, the current data exists that there are 4 or 5 trials already done on the drug withdrawal, and they have particularly not seen comparing biologics versus methotrexate or the conventional demand, what to stop first, right? So now this thing is novel enough to look at this part, and then it comes to a proper idea. So how do we assess the introduction? Have the authors reviewed the relative background literature? Because sometimes you read that ours is the first study to analyze that. Okay, but when you actually go in PubMed and see, there will be 100 study to do that. Okay, so that point is an off point, that this is not a good thing. Is the trial original? Now see, this question is very relevant, and let's accept it that many of the thesis is even not original. It's just copied data from the 10 years back study, right? Do not publish it. At least have that much courtesy, right? That we can't do that, but still it is happening. So is the trial really original or not? It is very important point. Okay, and you can only find it by a good quality of journal, good institute, and good people that who are actually doing this part. Okay, so this is tough part. Many of the time we review the articles which are given for presentation, or which are given for the publication. As a reviewer, my first job is I actually copy the title and see in PubMed whether similar research has been done. Sometimes surprisingly, what we find is the exact published research, someone is sent to a journal with his name, and that's a terrible thing, right? So it's upfront rejection with a red flag that this author is not allowed in publication process anytime in this journal. Okay, so that is happening. That you might be thinking there are so many articles. Let me pick one article. Let me modify a data little and let me send to another journal. But believe me, we can catch it. As a reviewer, most of the journals can catch it that this is a fraud. Okay, I will use the word fraud only, right? So that is not to be done. And now a very relevant question: what should be asked in introduction? You should have some idea when you are reading that who were the patient, what was the intervention done, what was the control arm, and what was the primary outcome. Okay, we will go a little more detail in all this when we come to the methodology, but these are important steps in introduction what you are going to get an idea. Okay, so an article, original article is not that big thing. You see the title, authors, you see the abstract and ignore the abstract first. You read the introduction, try to see whether introduction is enough to give you idea why this study was done and how actually they were doing it with this pico questionnaire, whether the research question was right or not. That's a step one. So when you make your JC in introduction part, you try to convey author's idea with your input also, that what happened, what author thought, that why this study should be done, and what is your input, whether it is real need or not, right? Because see, this study, again, I will just use this as an example. This is real need, that we have so many patients of rheumatoid arthritis. We treat them for 1 year, 2 year, and they are doing completely fine. So for last 1 year, my patient had no flare. The question comes, should I try to taper the therapy, right? So this is a research need. What research says about that, and that it becomes quite relevant there, that, okay, this is a correct article to discuss. Now, the heart of your journal club, that is a material and method which is given in your article, because that tells that how a researcher has conducted study and that conduct was good or not. Now, what I am going to discuss now, it is going to give you even 4 or 5 MCQ for sure if it's biostatistic, because that part will come, randomization will come, superiority, non-inferiority will come, intention to treat analysis will come. These are the simple terms we keep using. They are not simple. It took me a lot of time to understand, and still I get confused sometimes what is happening there. Okay, it's fine. But here, what we are actually going to discuss is, see, the ideal method is something, if a motivated reader reads it accurately, he can actually reproduce the trial. Okay, it is something when you are seeing your senior's thesis and you are trying to repeat it, the methodology is important. How he did it, can you do it in the same way? Then it's ideal methodology. But sometimes we find is he copied from the another senior, right? Then the things are screwed up. And sometimes we think it becomes easy. He copied, so I will also copy, right? Let the research be where it has to be. Fine. So these are something it's very sad that I have to discuss this, because we see these parts being in institute and all. So that's not a happy thing about our place, but we are not alone in this. This happens in Western countries also. Okay, so we are not alone in all this thing. So this is the first point. The methodology should be quite clear. Who were the study subject? How did they recruit it? And what were the exclusion criteria? Again, talking about exclusion criteria. When we have a thesis supposed to be done, that my thesis title during MD was vitamin D deficiency in COPD patient, a case control study. Okay, so I have cases who were COPD and I have controls which are healthy controls in a way. Okay, so age and gender match healthy controls. So then we include exclusion criteria, that we will not take patient with liver disease, we will not take patient with renal disease, we will not take patient who are on steroids, we will not take patients who are elderly. More and more exclusion, worst is the study, because you cannot extrapolate the result. Okay, the external validation of study will go very low, because see, now this was a vitamin D COPD. Now let me talk about a trial that you have a therapy available for a disease. Let's take again rheumatoid arthritis. Okay, so for rheumatoid arthritis patient, I have a new drug, and existing therapy is a methotrexate. Okay, now in this drug trial, one arm is a drug and second arm is methotrexate. But what I am doing is, I don't want to include patient with liver disease, renal disease, whose disease activity is high, whose age is more than 50, and patient who are male, I don't want to take. Okay, so for some reason. So more and more exclusion criteria. When I publish the result is not applicable to exclusion criteria patient. So my real use of drug will be very, very less. So it becomes a futile trial completely. Okay, so that is the point. We all have to be careful. Keep exclusion criteria minimum, include them. We know it will bias the thing, but mention that and know that bias and try to randomize the patient properly so that bias will go. Okay, so that is the ideal way, that we do not exclude so many things. For me, the exclusion is very simple. The patient who does not give consent should be excluded. It's obvious, right? We do not take them. Second, if your study is a questionnaire based, if a patient does not know the language of that, should be excluded. It's not kind of being I don't want to include this, and you should have a translation and you should actually know how to apply it. Okay, if you are able to do that, have a translation and a validated translation. That's again a headache as such to tell. Okay, so that becomes quite difficult. So try to keep a single language study. And but most of the time you will say, no, in our college they had English form, Hindi form, then the regional language whatever is running, and one more regional language form. I'm fine with everything. Keep it, because it's the institute decision. Okay. But the ideal way, when you are interpreting it, it becomes quite difficult, because when you publish that study and someone actually asks that, how did you do this questionnaire in Gujarati? It is not even validated in Gujarati. On upfront, your study gets rejected. Okay, that's a very important point. You can use only validated points. So either you modify that my all patients were knowing English and I enrolled my patient who were knowing English only. Otherwise, you get a rejection there. The first thing is terrible. The second thing is okay. Rejection is learning, but telling lie is odd, right? So that is the thing we have to keep in mind. Now, this you will read the trial, whether it is a non-inferiority trial, equivalence trial, or superiority trial. Okay. See, we do this thing in life every day. Let's take any kind of let's talk about a cricket team. Fine. So we say that India is a good cricket team, and Australian says no, we are superior. So the thing is, how we ask now, how you are superior to India in cricket. So then they will tell 1, 2, 3 criteria are better. So we are superior. So we have to taste that whether the criteria is real better or not. That's a superiority thing. Okay. Now the second is equivalence trial. So Indians are telling we are equal to you. Now, when you tell equal, you have two questions, that we are not better than you, we are not worse than you. Okay, so you have more criteria to fulfill. It requires a larger sample size compared to superiority trial, right? So when you select your study design, you have to be actually careful. Now the third part comes, the non-inferiority trial. The India A team, okay, they tell we are also like Australian team only. Okay, so we are not worse than Australian team. That's called non-inferiority trial. Now let's forget the cricket and come to the real world of our therapy. So now the two drug company comes to me that, okay, I sell pantoprazole and I also sell pantoprazole, but my pantoprazole is better than his pantoprazole. Okay, so how do you prove it? Most of the time it's a superiority trial. Already existing intervention, if you are comparing, most of the time it's a superiority trial. Then comes the equivalence trial, that he is actually selling the pantoprazole, I also sell pantoprazole, you prescribe one of them, we are fine with that. So that is with equivalence trial. And now the most important non-inferiority trial. Let me give an example of lupus nephritis, where you actually use cyclophosphamide and MMF, right? So initially cyclophosphamide was the kind of thing which everyone accepted, that's a induction drug of therapy. Now MMF came, and MMF initially cannot tell, look, we are better than you. Okay, it becomes very difficult. They cannot tell we are equal to you. How do you enter in market? You tell we are at least not worse than you. Okay, that's called we are not non-inferior to you. So when a standard treatment exists, a new treatment is coming, what design you use is a non-inferiority trial. Okay, so majority of trial you will read in your tenure will be non-inferiority trial. Superiority is something a very challenging part. Okay, so that is the thing. Now see the what happens at initial point only, when you have a design of superiority and you do not prove the superiority, like Australian team told that no, we are better than you, and then criterias are not fulfilled, then they will tell that no, we are at least equal to you. You can't do that. Okay. Once your design is superiority, the sample size is fixed. You cannot change to non-inferiority or the equivalence there. Okay. So that is the thing about superiority trial. Even though it looks the sample size required is very less, but you have to be so robust to be superior. Fine. So when you choose a design, the non-inferiority is the best design to start with. Okay. And believe me, do not take randomized control trial as your thesis. We cannot do in 3 years. We are learning still. We have a lot of clinical stuff and all things. We cannot conduct a non-inferior trial. Ideally, a practicing clinician should not conduct a trial. He should have a research assistant who can conduct for you. You can just give them patient that, okay, this is lupus patient who will come into trial, do the necessary things and do the clinical part there. Okay. So this is the ideal thing. But in India, postgraduate is like kind of, he can do anything, right? So he or she can do anything. So give everything. It's fine. Now, again, the next comes is the sample size. Now, here also the thing is, see, this is the first line to read. A study's power is the probability that the study will detect a difference between the intervention and control group if a true difference exists. That tells if your study is powerful enough, if your sample is adequate enough, then only your study makes sense. Otherwise, it's a dustbin thing. Okay, so that is very important to know, that if study sample size is not enough, it is useless to read that article. It is useless to even show off that I have a publication on that when the study sample size is not enough, because it is actually not addressing the question you asked. Okay, so that is the point, the study sample size. I'm just giving an example here that ideally a study should have 95% confidence interval and at least 80% of the power. And the difference, right? You have a group 1 and intervention 2. And if you think that 20% difference is significant, you just put this in software and they will give you the sample size. And on that, you will add the drop rate. Drop rate is quite important. When you read an article, if an author is mentioning that our study sample calculation was done like this, and the drop rate was calculated around 10-15%, and we additionally included that as a sample size, that's the best thing, right? Because everyone who comes into a study or trial will not stay into study or trial. So we cannot lose them, right? So we be prepared to take more sample. Now, does it really matter? Yes, it matters, because your sample size will determine your funding, that I need 100 patient rheumatoid factor to be done. So I need this much money. But if I just ask for 90, and my 10 patient drops out, then I have to take 10 additional, no one will give me money for that, right? And I won't spend from my pocket for research, right? So it is not good to spend from pocket for research. Until unless we are asking that seniors thing to copy, you have to spend from your pocket. Okay, that's fine. But this is what, that this is important point when you're reading an article, how the sample size was calculated. I'm pretty sure that what we are discussing is for some people, they're well versed, and for some people it is something here. We don't do all this thing. We just copy paste the article, we present, and the discussion gets over and things are done. Okay, it happens in most of the places. But we have to be careful when we read article, because see, if it is not done properly, there's no point, right? The study. Was the trial controlled? So we have three kind of control. You can either control with placebo, you can control with the established treatment, or when you can control with conventional treatment. Placebo is something that when the no therapy exists, this kind of placebo control trial is good, right? Again, let me take an example, rheumatoid arthritis. If a new company comes that, okay, I will give this drug versus placebo, I will kick that company, because rheumatoid arthritis already a standard treatment exists. So I will compare it with the standard treatment, then only the drug has entry. Sometimes the conventional treatment means what? We do not have an exact protocol. Let's take a sepsis study, right? So in sepsis, it was goal-directed therapy versus a conventional treatment. Conventional means what we were doing, we continue doing that. And the other patient goes into the goal-directed therapy, where we actually measure everything and see if this is not achieved, again, increase the dose, escalate the dose, everything we do according to that. And then we compare that doing a GDT, goal direct therapy, versus what we were already doing, what is better, right? So that's a placebo, or like that's a comparator arm for that. Second, the randomization. I will discuss about this in the next slide and it will help. and third is blinding. That also I will discuss. Okay, so the first part is the randomization, and people ask, and say this is even your PG full question also, the randomization methods. Sometimes it comes in theory, and so many time the concept comes in your MCQ also. So randomization, what are the method? First is very simple. Take an envelope and write something that whether you will go to group 1 or group 2, and patient will decide, the patient whatever he picks up, he will get one of the therapy. Suppose one is cyclophosphamide, second is MMF, he got one, he get this. Okay, second is something called random sampling, where you do is you have a lot of patient, and there is something that you cannot take all the patient and all. You will be randomizing in a way that every third patient will receive cyclophosphamide. Okay, that's called fixed random sampling, where n is fixed. Or here it will be something that exactly not known. Every third, seventh, ninth, 11th patient will receive this therapy. Every first, fifth, sixth patient will receive this therapy. That's called complete randomization, and this is called fixed randomization allocation. Then comes a block randomization. Here, see, blocks are important sometimes, because suppose if we are using this, okay, the simple randomization, and what we got is that I had total 50 sample size, 25 were supposed to receive N1 and 25 were receiving N2. By some chance, my first 20 patient got N1 only, no one was getting N2. And suddenly something comes that, okay, I cannot recruit much of the patient. So my everything goes waste. But if I make a block that I will first take 6 patient, and out of 6, 3 will get therapy A, 3 will get therapy B. When this is complete, I will go to the next block, again 3, 3, and that I will continue. So at least my distribution is somehow controlled equally. Okay, this is called block randomization. The next randomization is called stratified randomization. Now, stratified randomization is sometime important, specifically when you are allocating a treatment to group A or group B. And sometimes it happens in group A, every patients are hypertensive, while in group B, there is no hypertensive patient. So the study might get tilted. So what you do is, out of your patient, you divide it hypertensive, non-hypertensive, and then you start a randomization. Hypertensive patient, you get this, non-hypertensive patient, you get this. So you get a strata, and you try to make it equal. So your group comparison will be fine. So I think this will help you simply. That suppose you have a 16 patient, by simple randomization, all 16 will receive either a black therapy or the white therapy, and it will be 2 random. In block, again, you have 16 patient, but first I will complete block 1, 2 got black, 2 got white, then I will complete block 2 and will go like this. In stratified randomization, what I'm going to do here is I'm going to divide in my total 16 patients. These are hypertensive, these are non-hypertensive. Out of hypertensive, 4 will receive black, 4 will receive white. In non-hypertensive, 4 will receive black, 4 will receive white. So that makes a lot of sense that groups are comparable. Okay, so these are little easy things, but they just make it tough. So this is very simple way. I'm not going into minimization, randomization at present. It is something first patient you select, and it is a dynamic randomization depending on what is your next patient characteristic, the randomization keep changing a little. That's called minimization randomization. Most of the time it is a stratified randomization or block randomization which are used in the study, because it makes a lot of sense, right? So you will get a lot of question on randomization, and where you should be knowing these are the methods on that. Next is the blinding, and we all were taught it's a single blind means patient does not know, double blind means patient and assessor does not know, triple blind means patient, assessor, and the person who is analyzing the data does not know who got what therapy. Okay, this is very confusing. So it says that do not use the single, double, and triple. Directly tell who were blinded. Okay, so the patient blinded study, caregiver blinded study, data collector blinded, data interpreter, or statistician. Ideally, everyone should be blinded to get a good result. Otherwise, a company tells that I'll pay you a little more money, show results like this. That should never happen. That's a thing that we do not. Or sometimes as a physician, we feel, yeah, this patient is sick, he should receive this therapy only. He cannot get placebo at all, right? Then the purpose of trial is defeated. You be good with your patient, but don't say that we are doing a trial. Okay, so that is the important point to take. So this is all about your blinding part. Now there are certain trials which will be written open labeled, because sometimes you cannot do blinding, right? Suppose there is a you are doing a procedure for aortic stenosis, you cannot do blinding here. The procedure is done or procedure is not done. There is something called sham control, that you do the intervention but you do not do the exit thing. Okay, suppose we take any operative therapy, you put incision but you do not operate them, it's called sham control. Okay, so that is valid in some intervention but not all the time where we discuss it. Okay, so this material method is a part of study. You are actually going to little more in detail how samples are taken, how randomization is done, how blinding has been mentioned, and the next thing, what are the endpoint. Now this is very important, believe me, still I have 10-15 minutes to discuss with you if you can stay on the discussion, right? Fine. So the next point is to see the endpoint. Now see, endpoint will be two things, primary endpoint and secondary endpoint. What do you mean by primary endpoint? Primary endpoint is endpoint through which you determined what was your objective, why this study was done. Okay, so in this study, if you can see, the study was done to see at 1 year after withdrawal of TNF inhibitor versus conventional DMARD, how many patients relapsed in each arm. That was the primary endpoint. After that, they had so many endpoints which are called secondary endpoint. Okay, so sometimes what happens is you have been given a thesis and your primary endpoint was to compare this versus this, and it does not come significant. The p-value does not come significant, and your boss is screwed or you are screwed. So it tells, okay, forget the primary M. You see what other differences are existing where p-value is significant. And then what we do, we publish that study as the p-value is significant for that. But believe me, you calculated your sample size on primary objective. Now you cannot publish is not powerful enough to assess that. Okay, and a good reviewer will catch it and will reject your study upfront, telling that this is not the way to do research or this is not the way to do an article publication. Okay, this happens with good journals, believe me, because someone might be thinking that if I give 10,000 rupees, now there is one journal who publishes study. I might have more publication than you with 10,000, 10,000 and like that. Okay, they're rubbish. Okay, it's okay that no one knows what is rubbish. Fine. So this is how the things are going on. So endpoint, you have to focus on primary endpoint. And see, this is a very clinical message. As a practicing clinician, you should only pay attention to the primary endpoint. Only primary endpoint should be used to make clinical decision. Don't focus much on secondary endpoint there. Okay, and this is the example of the study what we are discussing, that they actually took the primary endpoint as a simple proportion of the patient with the disease flare within 1 year. That is a primary endpoint. Secondary endpoint was so many. What is the difference in this, right? So you cannot actually go on secondary endpoint directly. It helps you more. Obviously, the secondary endpoint helps you more, but what you go on your research is always the primary endpoint, which is going to help you even more. Fine. So that is the part we have to be careful on that. So what endpoint you decide on your sample size is primary endpoint. When you write your thesis, it is on your primary endpoint, whether your thesis satisfied the primary endpoint or not. Okay, so this you will face this, and it becomes so difficult because your guide told कि यार endpoint change करना है, right? And will be यार if I don't change, he won't sign. If he does not sign, I'm not eligible for exam. So for that moment, do it. But when he tells कि अब publish करो, if you passed the exam, register it. Then no, sir, we are not going to publish this. This is not fair to science, right? You should have at least have that guts to tell. Okay. But otherwise we will be like more kini yaar bhi publish bhi kar dete, 10,000 only takes. Fine. So 10,000 is not a problem. The problem is wrong science, right? So now here we sometimes see this question as a per protocol analysis, intention to treat analysis, and as treated analysis. So before we go in a deeper understanding of this, this is how we do a trial. When a randomization is done, either you get intervention group or you get a control group here. In intervention group, there is a 2 chance that patient is taking therapy or patient is not taking therapy. It is his choice, right? In control group, there is again the 2 chance. He is taking therapy, he is not taking therapy. Now, when you do intention to treat analysis, you respect the first randomization what has been done. Whether patient takes or do not take, you take in that group to compare. Whether patient takes or do not take, you take that group to control. In per protocol, what you do is, if patient is not taking therapy, you drop it here. Okay, if patient is not taking therapy, you drop it here. So it is something, if patient is compliant, then only you consider per protocol analysis. In intention to treat, you consider irrespective of anything. Now see, this is very important. If my patient in group A are developing side effect and that's why they are stopping the therapy and all, if I do not consider that, that's not fair. I will be giving, because it tells the drug works in the patient who take it. I actually don't want that. I want drugs to work to whom I'm giving. Okay, I have to make someone silent. Yeah, fine. Okay, so this was a very important line to revise, that I don't want a drug to work in a patient who are taking. I want my drug to work to whom I'm giving, right? That's a approved drug. That's the kind of drug a doctor will prefer. Fine. So that is intention to treat analysis. If patient is taking and it's working, it's called per protocol analysis. Then third is the worst analysis. It's called as treated analysis. If patient takes the therapy or do not take therapy, accordingly you take it. So it's kind of doing a cohort study. Now you have a three kind of analysis, and believe me, this is the point you take a screenshot. This is very important. Intention to treat is a gold standard analysis. It compares outcome based on original randomization scheme regardless of the eligibility, non-compliance, crossovers, and loss to follow. Per protocol analysis compares the outcome based on the actual treatment received among those who were compliant. Analysis drop non-compliant, and this all are your small MCQ point, that in PP analysis the drops the non-compliants are considered, they are dropped, right? They are dropped. It asks whether the treatment works among only those who are taking the treatment. As treated analysis compares the outcome based on the actual treatment patient received regardless of the original assignment. So why did you do the randomization even, right? So as treated analysis is not an allowed thing at all. In an ideal scenario, you have to do ITT. That's the intention to treat analysis, nothing else. Okay. If you are doing PPA, per protocol analysis, still you have to mention what is the reason you are not doing intention to treat analysis. So when you read that result, the methodology part, that the analysis was done as an intention to treat or per protocol analysis, you be judgmental. If it's ITT, the interpretation is really good. It's per protocol analysis. The company is trying to tell, if you take the drug, it will work. But what I really want, if I give the drug, it works. That's the intention to treat analysis, right? So now the last few slides. This was the method, right? So method is literally you have to see and see the heart of the article in a way is a method. If the things are done correctly, every other thing will be good. Okay, so the introduction gives an insight what researcher was thinking. Material method will give you the thing what actually the researcher did. Okay, and third is just an outcome. Now he just has to present the data, what has come. So the first example or the first thing in result you see is the how good was the randomization. If you have that article open, just open that. They must have compared the baseline characteristic of group A versus group B. Now see, this is very important. Here your p-value should not be significant. That means the study groups are comparable. When p-value is not significant, both groups are equal in statistic terms. Means you can compare, right? Otherwise, someone's age is 30 and group B age is 60 and they are not comparable, then the trial completely fails. So you're the first table what you get in result is a comparison of a patient characteristic. They will start with demographic characteristic, clinical characteristic, then they will go for the laboratory characteristic, then they will see the comorbidity. Everything should be equal. Now see, you will read few lines. In Caucasian population, low dose of cyclophosphamide works as good as a high dose of cyclophosphamide. Means the trial was multi-ethnic, but only in Caucasian they found that it works equally. Otherwise, high dose cyclo is required, right? So that is the point. Reading it is it is very important whether the things are comparable or not. You can get it. Second is what was the dropout rate. If dropout rate was too much, again, it is not that great drug. Drug works, but if patient does not drop out, if does not develop side effect, if I tell that my drug Z is working really good, but 60% of patients who took it had to stop the drug because of some side effect. So it will work only for 40% of patients. So when I come to clinical practice with this drug Z and I give to 100 patients, 60 in India are going to abuse me. Ki, yaar, this doctor has given a drug and I developed this side effect. 40 will be telling, okay, it worked, and who cares, right? No one gives a positive thing. It is all negative in India. So everywhere almost that you give the drug, it caused me side effect. So that's the point. If dropout is too much, that's not actually a good thing for a trial. And what were the result? That's your primary endpoint, whether the both group were similar or non-similar, right? Whether drug A was similar or not similar. So there you find actually what actually works in a better way. Okay, fine. After result, you have the last part, which is discussion. Okay, and see, now you have an original article in your hand, what you have selected from a reputed journal called Lancet, NEJM, JAMA, or Annals of Internal Medicine, Chest, Blood, whatever. You have seen this article, you have seen the title of article, authors of article, abstract, you have ignored it, which we never used to ignore because that was the only part we were reading. You have ignored it. You have read the introduction, you have read about the material methods, you have read about the results, and you have taken all this step in consideration while making the last part is discussion. And believe me, this is the toughest part for the author. Discussion is very simple thing in a way. I'm just telling simple, but believe me, I have so many papers stuck at the discussion point. I have introduction ready, material method ready, results ready, but discussion is difficult because there the honesty comes. Do we really need this paper to be published or not? Okay, so the first thing is, do the conclusion follow logically from the result? Because in discussion we will be telling that we did this trial and we saw this much thing and we think this is the reason we got this result. Okay, so whether it's a logical sequence or not, then we will compare with the already published study that they found this difference, we found this. The reason being for that difference could be this. That's called the comparison. Third is the limitation. Okay, limitation wise, you will write that we tried doing this, but due to COVID, we could not recruit enough number of patients. That's a worst thing, right? It's a fact. You are being honest here, but you could not recruit enough number of patient. That tells you that the study is not powerful enough to ask or assess the question you actually asked. The difference exists or not. Okay, it happened to my DM thesis that we had a lupus nephritis trial where each arm was requiring 107 and 107 patients for two therapy. With COVID, I could not enroll that much. The study is not published. Obviously, it is not publishable. But what we did is we wrote the thesis and we submit the thesis. And in that, we mentioned that we could not enroll because of this reason. Here, the thing to learn is because I wrote, I got a qualification certificate to write my DM exam. So it is important at that point in thesis. You cannot tell your guide ki, sir, sample size achieve nahi hua hai, so I am not going to write my thesis. You have to write it, fine. But you do not publish it till you achieve the proper sample size, because otherwise it's a useless thing. We do not need that. Now, the last part, what I'm not going to discuss in detail, because I think this much is enough for all of us to actually know how to prepare a journal club. When you're reading the article, in each title, what are the points you are going to respect here, right? Once you are thorough with making a presentation of journal club article, there will be a stage, and believe me, it will be, if you are sincere enough, then when you will be judging the people whether they have done it right or not. And most of the time, it's a reviewer's job when they get invitation to review article which has been sent by an author. Okay, so the first thing we do is we actually ask a question: is the basic study design was valid for a randomized control trial? So you have to ask a few simple questions, that whether this pico kind of question was built up or not. If yes, it's good. No means it is not that great. Can't tell means you are confused and the author is confused, right? Second, was the assignment of participant to intervention was randomized or not? So by reading the article, can you tell it the questions or not? where all the participants who entered the study accounted for as its conclusion, means the analysis was intention to treat or not, right? Then if this criteria are fulfilled, you go to section B. Was the study methodology sound? Where you ask this question and you try to assess. You Google critical appraisal checklist and you will get this thing. Okay, so definitely it's all available online. Then you see what were the results and how the questions were formulated. And last, which is most important, will the result help locally? A study is published in European country and we all are discussing ki naya paper aa gaya, naya drug aaya. Okay, the problem is, can you really use that drug in your setup tomorrow? That's the question to be asked. So it's called local adaptation is possible or not. Can the result be applied to your local population in your context? Okay, so the first is, are the study participants similar to the people in your care? Because you get an article that this drug has shown the cardiac benefit, but none of the patients were Indian. So that's the first point, whether I take it or not, or it's an invitation to conduct a trial in India, right? So that is the first point to consider. Would any difference between your population and the study participant alter the outcome reported in the study, right? Some things are ethnicity based, so that is required. Are the outcome important to your population, right? Because sometimes tells that if you take this drug, you feel happy, and my population is tell we are already happy, right? So that's a kind of just a metaphorical comparison, but we need it, that it really matters or not. Are there any outcomes you would have wanted information on that have not been studied or reported in the trial? And are there any limitation of the study that would affect your decision to apply in your patient? So this is very important, right? At the end of the day, this is important. What I read, what I analyze, does it help my patient or not? Okay, so that is the point we have to adapt. And then you see, would the experimental intervention provide a greater value to the people in your care than any of the existing intervention? A company comes to us and tells that, sir, my drug is really good. We did this trial and it was, patients were very happy and they improved and all. And we tell, no, yeah, with the therapy what I'm giving, they're actually doing very well. Okay, so I do not need a new treatment at present. If I found a lacuna that at this point I do not have any therapy, and this in that population, if you come to me with that drug, we will talk about that, right? So if someone comes to me now within a patient of hypertension where we have a good number of drug and without much side effect with a new molecule, he literally has to fight with us for a new introduction. It's not that he will give me some trip pen and I will be writing his drug. It won't work like that. Okay, that's the sole purpose of evidence-based medicine and a journal club, that when someone tells you this works, you say no, let me read whether it works or not. And this is how you read a journal club, and you critically appraise it whether it works or not. Okay, so last few slides are what can be possible outcome of a journal club. We learn in a journal club. If we want to learn, we become wiser, not necessarily healthier though by reading so much. You can have a publication if you really read it. I had one during my DM that when the journal club was done and after that we published, it will go to your logbook. So anyone who is still thinking after MD or DM, I want to go to US because I'm not happy here, it will add to your logbook, and that matters sometime to them. And the very important thing to learn, all of publications are not science. Some are compulsion in red dress. Okay, we get promotions on that base and all. And some people like to have numbers. I have 800 publication. See, you cannot have 800 ideas in your life. Forget it, man. Okay, we can have 4 or 5 original idea in life. So if someone tells me I have 800 publication, I will really love that person for his collaboration skill, that he got so much work done. Otherwise, you cannot write 800 article. It's impossible. There are people who will analyze things like this when you send an article. So how can you get 800 publication? It is impossible. Still, you have seen the people with 800 publication, right? It is a collaborative skill, and I appreciate that. Okay, it's not key you have to appreciate only science. The other skills also matters because that's how the world is going, right? So these are the things, and I will be thankful to this two institute. I was good with journal clubs.